Good morning, everyone. I'm Dr. Martin. Happy Saturday. Typically, I do not do lectures on Saturdays. I'm usually reading, which is actually what I've done for most of the morning. Now, when I do lectures, I do them for a number of different reasons. Sometimes I do them based on physician request. Sometimes I do them based on kind of topics that I see swirling on social media, and sometimes I just do them out of, I'm going to call it, pure, unadulterated anger. Just pure anger. And this is how and why I'm giving this lecture today. As most of you know, I talk to a lot of doctors, and I talk to them all across the country, all across the world. I hear all sorts of crazy stories, right? The lecture here is the nose knows. The premise for this lecture, and it's been a crazy busy week. I filed paperwork for an IRB, an international world-class comparative IRB. I'm talking, I don't know how many doctors I talked to this week, probably 100, maybe 120. On schedule, God knows, another 50, 100 off schedule. I leave in a couple hours to go to London for my 25th anniversary with my wife, who I adore above just about everything. But this was important that I filmed this in my office before I left town. I had a call with a doctor, and that doctor told me a story that shook me to my core. And I wasn't able to get a hold of the doctor in Costa Rica that did this because I'd probably get arrested. 2-year-old patient with autism was referred to this clinic. Never heard of the clinic. The doctor sedated this child, did a liposuction on a 2-year-old, harvested the fat, emulsified the fat, took the, quote, stem cells from the fat, under sedation, did a lumbar puncture, and did an intrathecal application of adipose-derived stem cells for that child with autism. I'm trying not to respond overly emotionally. If any of you saw my prior lecture on MSCs, we all know that the MSC molecule itself is between 15 and 40 micrometers in size. That's why if you give it IV, it's not going to cross the pulmonary capillaries and get into systemic circulation. It just gets sequestered in the lungs and dies. We're going to go through this quickly because that's not the point of the lecture, but it's the foundation. When I take adipose-derived stem cells, it is not possible to wash all the red blood cells off those stem cells. And so putting that in the intrathecal space, the body is going to mount an inflammatory response as those red blood cells die and release heme and release iron, incite a cyclooxygenase pathway that will release excitatory amino acids, glutamate, aspartate, calcitonin G-related peptide, and that child will get more neuroinflammation. Notwithstanding the fact that fat-derived MSCs are very chunky molecules. They are like at the top 35 to 40 micrometers in size. And there's a very real possibility that those chunky molecules, God knows whatever else is in that stromovascular fraction that was put in the intrathecal space, right? Is there possibility of plugging up the ventricles, the cisterns that drain all the CSF through the brain, track it through the spinal cord, Yeah, there's a very real possibility of that. Is there literature that just sedating a child with autism impacts negatively their neurodevelopment? Yeah, tons. I gave a whole lecture on this probably 2 months ago. So let me just wrap my head around this. I have a child with autism where one of the primary pathologies is neuroinflammation. And so I'm going to sedate them when we know that sedation impairs neurologic development in a child. I'm going to cut their belly and I'm going to do a liposuction because there's lots of fat on a 2-year-old, right? I'm going to harvest this fat, going to emulsify it, do whatever the hell I'm going to do, assuming that they had a sterile hood. Then I'm going to put a 20 gauge needle, maybe a 22 if we're lucky, into the spinal canal of a 2-year-old under sedation, probably monitored sedation, so they got a MAC, push this cell-rich, chunky crap into their spinal canal and just hope the patient doesn't get meningitis, some element of reactive neuroinflammation, which they're definitely going to get based on the activity of the molecules, right, and the breakdown of heme, and hope they don't get a secondary iatrogenic hydrocephalus. And, charge the patient's parents $25,000, $40,000. I can't say what circle of hell in Dante's Inferno that doctor belongs in, but it's pretty low, right? Like 6th, 7th circle of hell, right? Oh. All of you know me, right? If you don't, I'm an interventional pain doctor. I graduated from the Caribbean. I'm not smart, right? I wasn't top of the class. I've never been top of anything, right? Everyone watching this is smarter than I am. I've been sued to oblivion. I've been on probation for the medical board in the state of California and Nevada for 4 years. I mean, I've been through it all. But at my core, I operate on 2 foundational principles. Number 1, the Hippocratic Oath, do no harm. And number 2, as far as I'm concerned, the second Hippocratic Oath from the world's first healer, which was Christ, right? Do unto others as you would have done to yourself. Do you think that that pain doctor or whatever kind of doctor that guy was would ever submit his own child to that kind of torture? No shot, right? No pun intended, no shot, right? No prayer. And if he is or would do that, and he says he would, he shouldn't be a doctor. There's no space or place for this, especially when we have known literature that just sedating a child with autism can impair neural development. I'm beyond words. And so I had to walk through this. Now, on top of all the other things that I've been doing this week, this has been in the back of my mind because I had this conversation on Monday. And if any of you talked to me on the phone this week and I seemed a little perturbed, this is why. Because nothing infuriates me more than people overcomplicating what is actually remarkably elementary. Remarkably elementary. When we're talking about autism, when we're talking about Alzheimer's, Parkinson's, dementia, post-stroke dementia, long COVID with neurologic issues, chronic Epstein-Barr with neurologic issues, chronic Lyme with neurologic issues, fibromyalgia with neurologic issues, one of the primary underlying pathologies is just neuroinflammation. That's it, right? And from all of my lectures, you know that the things that we use systemically to down-regulate inflammation actually are catabolic in nature. And the reason we use umbilical cord-derived biologics is that they don't induce inflammation. They don't work by way of an M1 macrophage pathway that causes a pro-inflammatory response. They actually work by way of an M2 macrophage pathway. And in all honesty, this is all we're trying to do. We're just very simply trying to get a microglial switch of the phenotype from a type 1 to an M2 paradigm. Does that sound familiar? It should, because that's what we talk about with joint. If we have somebody with a grade 3, grade 4 knee, what are we trying to do? Take an M1 macrophage-driven pathway that's causing upregulation of inflammatory mediators, upregulation of IL-6, upregulation of IL-1 beta, upregulation of TNF-alpha, and downregulate that. Well, when we give an umbilical cord-derived exosome, of course, by experimental use, right? And I didn't want to qualify all of this. This is all experimental use, right? This is experimental use. Why? Because the FDA is your friend. And we cannot use any human cell and tissue product to diagnose, treat, cure, prevent disease, let alone neuroinflammatory paradigms such as autism. None of this is a cure for any neurologic disease. We are simply down-regulating neuroinflammation, and hopefully by doing that, by inducing a phenotype switch from an M1 to an M2 microglia, in down-regulating inflammation, the body heals itself at a cellular level. I have, 15, 20 references below this lecture. Again, you don't have to believe me. I don't care. I've read the literature. I know the literature. I'm doing this for all of you so that you can read the literature as well, and then you can make your own determination. In a child or an adult, you can simply nebulize exosomes. You can simply nebulize nano air plus 2 to 3 cc's of normal saline, and literally breathe in through your nose and exhale through your mouth. And you will get movement across the olfactory mucosa, the trigeminal projections into the sphenopalatine ganglion, the cribriform plate itself, and the nasal venous plexus, which will distribute biologic into the forebrain, into the brainstem, higher brain centers, the cortex, the hippocampus, the midbrain, and then secondarily come back and cross the blood-brain barrier again as that biologic gets dumped into the nasal venous plexus and makes its way back through a second time. Now, the mechanistic paradigm is very simple. Primarily, we are down-regulating TLR4 and down-regulating NF-κ beta. And in so doing, down-regulating tons of inflammatory mediators, up-regulating protective mediators, and essentially allowing the body to heal itself at a cellular level. Now, if it's downregulation of IL-1 beta and TNF-alpha and IL-6, we're familiar with that because that happens in a knee joint when we use something like an exosome or even a Wharton's jelly because they work by way of an M2 macrophage pathway. But we also get wonderful downregulation of excitatory amino acids, calcitonin G-related peptide, nitric oxide, substance P, pituitary-derived polynucleotide, It's called PACAP. It's incredibly complicated, but it's very potent when it comes to neuroinflammation. And if you can down-regulate that polynucleotide, it imparts a protective environment wherein the body can actually heal itself at a cellular level. Now, I see all sorts of nonsense, just complete nonsense, on sphenocaths and on nasal injections. And all I have to say about that is this, all right? Number one, if you're going to stick a needle into the cribriform plate, unless you are max fax, ENT, or neurosurgery, you have no business doing that. All right? There are very good case reports of death associated with the needle going through the cribriform plate, biologic being dumped into the brain itself. All right? If you're not qualified to repair a defect in a persistent CSF leak because you knocked a hole through the cribriform plate, you have no business putting a needle there in the first place. Sphenocath. Lots of people selling sphenocath. Everybody loves sphenocath. Total bullshit. All right? First and foremost, ideal paradigm for sphenocath is wedging that catheter between the superior and middle turbinate, juxtaposed or onto the sphenopalatine ganglion, putting the patient in reverse Trendelenburg, and then dripping 1 drop of biologic on the sphenopalatine ganglion every 3 to 5 minutes. That's Chinese water torture. You wouldn't do that to yourself. Even if you do it that way, right? You got to hope and pray the patient's endolymph didn't go nuts and you didn't give him vertigo for just having done the procedure. But we all know what actually happens. You push the biologic too fast. And when you do, the nasopharynx is continuous with the oropharynx, and they do this. Tell me, what's the bioavailability of umbilical cord-derived exosomes in the GI tract? How much neuroinflammation are we getting if I swallow the biologic down and it goes into my stomach? How about none? How about that was a wonderful waste, right? Just simply put a mask on their face and have them breathe, all right? Yes, I know. Oh, well, we're losing exosomes out the side of the mask. Yeah, that's why we're using billions, 50, 90 billion, 180 billion exosomes, because we plan on that. There's a ton of information here, a ton. I've spent 10, 15 hours reading all this week. I've taken at least 3 to consolidate it all into a lecture and into a huge body of information that you can access at your leisure below this lecture. But central to all of this is just a simple want and willingness to, number 1, do right by patients, and number 2, just keep it simple, right? You're not going to cure somebody. You're not even going to impact neuroinflammation with a single application. So don't plan on that. It's going to take a couple applications, because if there's a lot of neuroinflammation, patient had a massive hemorrhagic stroke, right? And you want to try to down-regulate neuroinflammation, that's going to take a while. It's going to be 2, 3 applications and then maybe quarterly for a period of time. Somebody has advanced dementia or Alzheimer's, again, on an experimental use, right? It's going to take more than 1 application. So for the love of God, be patient. Now, I have more homework to give you, right? Because I will be creating a jot form for this, for neuroinflammatory paradigms, so you can do observational research and you can use patient-reported outcomes to track the progress of some of these folks that you're seeing, right? If it's a child, you're going to have an adult fill it out, mom and dad. I'm going to leave you with this one last thing, all right? All of you are on the forefront of medicine. And you're on the forefront of medicine for a very simple reason. You're not doing what everyone else does. You're not comfortable, you're not satisfied just simply cutting a script or clocking it at 9 and leaving at 5, right? It takes a lot of effort to digest this information. It takes a lot of effort to sit and listen to me ramble for 40 minutes or 30 minutes and then read all of this literature. But if this is something that interests you and you want to offer more to these patients, I strongly encourage you to lean in. Build your fund of knowledge. It's actually really elementary. Because you may impart a wonderful improvement in a patient's quality of life. And I can't tell you how much suffering a parent has when their child can't simply say their name. They can't use the word mommy or daddy. I can't tell you how much suffering a patient has when their loved one doesn't remember who they are or who their family is or who their spouse has been for 50 years. We cannot save everyone. No one is going to be cured. But if, even anecdotally, we improve the quality of life for a patient, it has reverberations. You improve the quality of life for a parent with a child with autism, and that parent's life is better. They're better to everyone else in their circle. Everyone around them when they're driving, everyone when they're traveling, everyone when they're working. And so it is a wonderful honor to work with all of you, because that is what you all are doing. You are creating the change that is reverberating, not just through your own community, but through a global network of people who are suffering. And in that, you are making the scholastic and the financial efforts to make their lives, and essentially all of our lives, better. I am in wonderful and humble debt to you. I'm Dr. Martin. Have a very blessed day.